Welcome to Olive Nurses Academy. Let's start our today's section. It is the pediatric nursing. Okay, so we'll see one by one. In the pediatric nursing, what you have to remember, we have already seen few conditions in the medical surgical already, the adult section. Okay, but the pediatric nursing, especially for the children, some of the clinical manifestation will be differ. Okay, some of the things will be management will be differ. So that's why separately we are seeing the pediatric nursing. So each disease condition taken from your previous question paper. So everything is important. Remember that. Okay, don't skip anything. So try to take out the key points. Okay. So we'll move on to the pediatric nursing. First, we'll call group syndrome. Okay, what is group syndrome? It is called laryngotracheobronchitis. That is a problem in the larynx, trachea, and bronchus. Okay, so mainly the causes will be patient will be getting because of allergy or some of the respiratory syncytial virus, okay, paravirus, these will cause, okay, so overcrowded places, babies will get the group disorder. Okay, so group, remember, laryngotracheobronchitis. Okay, so signs and symptoms, they will be complaint of mild bleeding, sorry, mild the fever, but there is a main signs and symptom, barking cough. Okay, remember, barking cough because the laryngeal edema will be present. So we will call group cough. Okay, that means the barking cough, it is like a dog barking. Okay, so that sound will come because of the laryngeal edema. Okay, so there is a stridor also because the upper airway will be obstructed. So there is stridor, wheezing will be there. So mainly we have two types, typical, atypical. If it is typical, means symptom more in the night time. Atypical means symptom more in the daytime. So that will be the diagnostic. Okay, so main point here, group, there is a laryngotracheobronchitis. So there is a barking cough because of the laryngeal edema. Okay. So next one, you have to remember the barking of fever. You have to remember. So what is the treatment you will do? You have to assess the respiratory status and discharge teaching. You have to stand in front of the open freezer. If the baby having some barking cough, we need the cool humidifier air. Okay, so from where there is a cool humidified air, that will from the front of open freezer. Okay, that's why we will tell the mother to keep that in the emergency situation in the after discharge at home. Okay. After that, they have to come back to the hospital. So this is the one of the management. So other than that, we have to maintain pattern airway. Always the ABC is important, and we have to administer the humidified oxygen, and we have to monitor for the stridor. Okay, so there's a monitor for stridor because there is chance of the complete obstruction of the upper airway. So laryngeal edema we have to check, and we have to keep the baby is tripod position, increase fluid intake so that any secretion is there, it will come out, okay, mobilize, and all the resuscitation equipment should be available in the bedside. Okay, so that is the thing. So humidified oxygen you have to administer for the group patient. Okay. Other than that, the main management for the barking cough, it is the nebulization, adrenaline nebulization. Usually we'll give the Epravent and the salbutamol, right? So here, especially because of the barking cough group patient only, we will administer the nebulization with the adrenaline. 1 ml adrenaline, we will just giving. So the nebulization, okay, to decrease the edema. Okay, got the point? And we have to avoid the cough syrup because the cough syrup will cause the thickening of secretion and airway will be obstructed. So we have to avoid the cough syrup and corticosteroid we have to give. So what is the diagnosis you will write for the group patient? It is ineffective airway clearance related to laryngeal edema. Okay. So ineffective airway clearance related to the laryngeal edema, it is a diagnosis. Okay. So move on to the next one. So this is about the group. You have to remember the adrenal nebulization for barking cough. Barking cough, it is the group cough. It is the important signs and symptom. We have to avoid the cough syrup. What is the diagnostic? Ineffective airway clearance related to laryngeal edema. Okay, so there is an involvement of the group laryngotracheobronchitis. Okay, remember the point. So next is called the epiglottitis. So we have already seen the epiglottitis. See, here also we will see because this is the important condition, life-threatening condition. See the epiglottitis. See, there is an inflammation. So completely there is only small amount of space for the airway to enter. Okay. So it is a deadly medical emergency. So I have told you already, epiglottis only opening when you are eating, it will be just closing the lungs, okay, closing the trachea, so that the esophageal open when you eat. Only esophagus, trachea won't be allow the food. It is closed by the epiglottis. And when you breathe, it will just close the esophagus. That is only happening for the epiglottis. Okay, epiglottis. So it is inflamed now. The flap is not working. So whatever food is eating, it will, there's high chance of aspiration go to the trachea. Okay. So signs and symptoms, you see the child is very anxious and restless behavior. There is a stridor because upper airway obstruction. Okay. There is a fever and a drooling of saliva not going inside. There is always, if you see the baby child is maintaining tripod position, leaning forward and opening the mouth like that. Okay. So these are the signs and symptoms mainly caused. It is because of the influenza virus. Okay. Hemophilus influenza type B. And there will be if they missing the standard vaccination schedule, vaccine and all in the vaccination schedule, if they miss that, there is a risk for the patient will be epiglottitis. Okay, so this is the important thing. Missing the standard vaccines also will cause the risk for the epiglottitis. Okay, so here the priority always the airway. Okay, so we should not do the throat assessment or the oral temperature. Why? Because you are just inducing, you are tempting to the, you are touching the tongue, and there is a temptation and there is inflammation can occur more. It will be cause the further inflammation, obstruction of the air. So until the patient is, you are just inserting the endotracheal tube or the tracheostomy tube, you should not be normally doing the examination. Only for the endotracheal ET tube and the tracheostomy, you can just insert and do the procedure. Otherwise that, no inspection, no oral temperature. Got the point? Then the tripod portion, it's good for the child, and we have to standard immunization this child. Okay, so otherwise we have to treat that according to the symptom. Okay, so here the see which clinical manifestation are appropriate for the acute epiglottitis. It is the patient will be having the pain, fever, drooling, trepitation, all will come. Okay, which student action will be the nurse need to correct when caring for the child with epiglottitis. Take an oral temperature. No, we should not take the oral temperature because there is already epiglottitis. Okay, so you have to correct. The nurse should be correct the student. Got the point? So next question. Next topic will be cystic fibrosis. We have already seen this one also. Just we will review. There's abnormal gene transmission. Okay, GFTR. Okay, what is the gene is affected in cystic fibrosis? GFTR. Just remember that. It is incurable. Okay, mostly you have to remember there is a problem in the respiratory because it is caused the sodium and the chloride transportation will be inhibited. So there is abnormality. So what is happening? There is a sodium chloride will be stagnated. So all the secretion is very thick. Okay. So it is an incurable disease. So if it is very thick secretion, we'll call obstruction. So first priority, always cystic fibrosis. It is the respiratory failure. Okay. So that you have to remember can cause the death also, respiratory failure. So the important priority, you have to remove the respiratory fluids. Okay. So what is the diagnostic test they will do? Sweat chloride test, quantitative sweat chloride test for the confirmation test. And the pancreatic enzyme, they will be just giving amylase, lipase along with the mix. Why? Because pancreatic enzyme also very thickening, not coming. So not secreting, what will be happen? There is obstruction in pancreas. So we have to provide amylase lipase in the diet through the each meal. Okay, pancreatic enzyme. Don't forget, because that is only helping to digestion. So this is about the cystic fibrosis, respiratory failures. Okay, that is a complication. You have to be look for that. Respiratory distress syndrome, otherwise we will call hyaline membrane disorder. Okay, respiratory distress syndrome, otherwise called hyaline membrane disorder, mainly for the preterm baby. Okay, preterm baby, what I have told you already. Have you remember? Preterm baby, what you have to remember, there is a chance of the lung maturity will be low. Okay, so there is a lung maturity low because the surfactant will be produced when it will be after 24 weeks started, that surfactant will be producing, and till the term it will produce. So preterm happen, what will be happen? There is no enough surfactant. That is only surfactant only preventing the patient from the lung collapse. Okay, we have already seen in the respiratory system condition. So you have to remember it is the mainly hyaline membrane disease or respiratory distress because of surfactant deficiency for the children. Got the point? So what is the drug of choice? If the baby in the mother womb will give the injection to the mother, okay, betamethasone or dexamethasone will given during the labor period, okay, antenatal period itself. If the baby is come out now, respiratory distress happen because of surfactant deficiency. What you have to do? You have to administer the surfactant directly inside the ET tube. Got the point? It cannot, it should be directly go and reach the lungs. So it is the ET tube route we will administer the surfactant. Okay. So next one, why we are giving the antenatal betamethasone or dexamethasone? It will be increase the secretion of the surfactant to the fetal. Okay, to mother we will give the betamethasone or the dexamethasone. Okay, so for the baby it is surfactant only. It is directly eaten. Next one is called tonsillitis. Okay, the children are most prone to get tonsillitis. It is recurrent tonsillitis. We will be removing. So what is the surgical procedure we will do? Tonsillectomy. It is when the surgery done, we have to be in the rose position. Rose position, I think that it is neck extension position. It's like a rose. Okay, that is a rose position we will see in the surgical. Post-operatively, you have to put the patient prone or lateral or siding, but never ever in the supine position. You have to remember. Okay, tonsillectomy patient after the post-operative surgery, you can put the patient in the prone or lateral or side lying. Okay, if it is breathing difficulty, you can put the semi-foul, but we should not put the supine position. There is an increased chance of the airway obstruction. Got the point? Frequent swallowing. The tonsillectomy baby, it's frequently swallowing. What is the indication? It is the indication of inside bleeding. Okay, and we have to be reduce the bleeding, reduce the blood, okay, sorry, pain. Okay, reduce the bleeding or reduce the pain. We have to give some of the cool water or ice chips to the patient. Okay, and we have to discourage the coughing. The main complication of the tonsillectomy, there is a eustachian tube obstruction or the ear pain. Okay, so tonsillectomy patient will complain of ear pain and eustachian tube obstruction also. Got the point? These are the complications. So these are the congenital disorder we were moving on to see. Okay. So what is the congenital disorder? It is called the heart. It's called the tetralogy of Fallot. Okay. We didn't study in the adult nursing because it is in the pediatric. Okay. Tetralogy of Fallot is the congenital defect in the heart. Okay. So this is the combination of 4 disease condition. What and all? See, ventricular septal defect, pulmonary stenosis, overriding aorta, right ventricular hypertrophy. Okay, so these are the hypertrophy. These are the tetralogy of Fallot. So tetralogy of Fallot having 4 disorders. See, ventricular septal defect. In the septa will be defect. Pulmonary stenosis, overriding aorta. Aorta also a problem. Right ventricular hypertrophy. Okay, so these are the tetralogy of Fallot. So where is the mainly there is a problem in the right side. Remember, right side only ventricular hypertrophy. Then pulmonary also will be pulmonary stenosis and overriding aorta and be right side. So right side there is a mostly there's a problem in the tetralogy of Fallot. Okay, so I'll move on to the next one. See, there is some of the question clinical manifestation for the tetralogy of Fallot. What and all the clinical manifestation you have to remember? There is an infant having there is a cyanosis. At birth itself, you see there is a bluish discoloration will be there. Okay, because the baby is born with the heart defect. Okay, congenital disorder in the heart. Okay, and the anarchic spell. What is mean by anarchic spell? Okay, so anarchic spells you have to remember there is a bluish discoloration all over the body. Okay, so it can be caused sudden death. It's long time there is a oxygen deficiency in the body. There is a oxygen more requirement for the infant. So it will cause what is the thing? There is a high risk for seizure can come because oxygen supply low in the hypoxemia. It is happen so low in the brain. So there is seizure can come, loss of conscious can come. Suddenly patient, the child can death also because so anesthesia, we will call anaxic spells or hypoxemic spells. Okay, so that and all will be same. Cyanotic spell we will call. So these and all same. So this case very severe. So I have to be just see the child carefully assessment. Okay, nursing diagnosis. What you have to remember? There is hypoxemia, so altered tissue perfusion. Got the point? Tetralogy of Fallot, where is it is located? I have told you on the right side of the heart. Okay. Child with the VST. Okay, ventricular septal defect. What is the blood flow character? They are just asking. So remember just ventricular septal is defined. So from ventricular, where is the blood flow will go? It's pulmonary. So septal is defect. So there is an increased pulmonary blood flow. Okay. So that is not decreasing because increasing because septal is defect. So there is increasing gush of the blood into the pulmonary blood. Okay, got the point? So these are the small point, key point, write it down. Okay, next. Child with the diagnosis of tetralogy of Fallot scheduled to the discharge from the hospital. Nurse who is planning discharge education should instruct the caregivers that during the hypersynotic spell, which position is most likely benefit to the child. So there is a hypersynotic smells or the anasic spells, or we will call it of the hypoxic spell also. So if it is like that time, we have to put the patient child in the which position? It is knee chest position. Okay, see the picture, knee chest position will be facilitate the to reduce the it's facilitate the oxygen will be borne to the all throughout the body. Okay, knee chest position. Don't forget. So next question. The nurse is assessing child who has tetralogy of Fallot. Observe the child having clubbing of fingers. Okay, so clubbing will be there like that clubbing. So that can be spoon nails also. That will be cholangias. We have studied already. So heart disorder can cause the clubbing of fingers or the spoon nails finger also. So which of the following might be the reason for the clubbing? Why the clubbing happen? Because the prolonged tissue hypoxia. Prolongedly that tissue it's not getting oxygen. So prolonged tissue hypoxia only cause this one. Got the point? Next one, the Foley's family is caring for their youngest child, Justine, who is suffering from tetralogy of Fallot. Which of the following question is used to congenital heart condition? So tetralogy of Fallot, what is the best position? It is knee chest position to facilitate the oxygenation. Okay. So this is about the tetralogy of Fallot. So here the cholangia see spoon-shaped nails can see, and the chest is like boot-shaped chest. Okay, tetralogy of Fallot, there is a boot-shaped chest. Okay, so what is the management we will do? We'll just treat the hyperspinatic spell first. That is a knee chest question. We will give 100% oxygen at the patient person. Okay, so knee chest question we will give 100%. We have to oxygenate the child, and we have to administer the to relieve the pulmonary congestion. Okay, we will just administer the morphine injection so that we can relieve the pulmonary congestion. Okay, so we can just give the patient rest because the movement will cause the more oxygen requirement. Okay, so why we are giving morphine? Not because of pain, to relieve the pulmonary congestion. You have to remember. Okay, so what is the surgery we can do for the tetralogy of Fallot? It is Belloc-Thomas shunt surgery. Okay, so we'll just repair all the 4 defects. That is called Belloc-Thomas shunt surgery. Okay, so these about the tetralogy of Fallot. So we'll move on to the next one. So tetralogy of Fallot is new condition. Don't forget the anasmic spell or the synatic spell. What is the position you have to remember? It is knee chest position. Okay. So next one is called rheumatoid fever. So rheumatoid fever already adult period itself we have seen. So we will just review. Okay, so these are the small condition only. But the thing is, you have to understand what is the disease condition. Then only you can be able to answer the situation question. Okay, rheumatoid fever. What is the causes of rheumatoid fever? That is mainly group A beta hemolytic streptococcus. Okay, group A beta hemolytic streptococcus will cause. So if you see the history, there is 2 weeks before there is throat infection or the upper respiratory tract infection with the streptococcus. It can be moved to the heart and cause the rheumatic fever also. So what is the confirmation test? We will do the ASO triad. Okay. So ASO triad means it is anti-streptolysin triad. Okay, anti-streptolysin. So we'll do the confirmation ASO triad in the blood test, and we will give the treatment. It's penicillin. It is a drug of choice. Okay, penicillin. And penicillin is very cautious because it will cause the allergic reaction. Very careful. Without the doctor is present, you should not give. The doctor will should be present and administer And sometimes doctor will give the test dose and the first dose will be connected by the doctor. Okay, so that should be very precautious. Okay, can be penicillin allergic reaction can be kill the patient within the 20 minutes. Okay, so that and all will be very important. Okay. Next condition, it's called hydrocephalus. Okay, in the hydrocephalus, what you have to remember, there is an increased CSF fluid collection in the brain. Okay, so in the brain only secreting CSF, we have seen in the neuro condition, okay, anatomy. So in the CSF, to lubricate and to be just applying the nutrition, we will just do the patient will be secreting CSF. That is the helping of the CSF. What is the function? It is like the cushion of the, it will be lubricating, okay, all the brain organs, and it will be doing the, what is the part? It is just secreting every day and reabsorbs in the bloodstream. Okay, that will be normal. So mainly it is in the subarachnoid space. Okay, remember the points. So it is secreted by the chloride structures. So thing is here, there is a CSF is secreting. It is going nutrients and supplying to every part, tissues, nourishment, and it is not going reabsorption. Okay, that is the problem. In case there is a one problem, there can be so much of CSF secretion, or there can be not just reabsorption happens. Sometimes some occlusion is there, something like that. So it is called hydrocephalus. Because of increased CSF, the patient will get hydrocephalus. Remember, so there is a symptom called infant-based syndrome, pediatric syndrome. Here itself there is differ. Okay, so infant have the frontanels under. So infant, if you see, there is a not the head will be not completely developed at the 2 years only. It will be bones are very strong, will be happen. So infant symptom like head will be very big, head circumference will be increased. There is sunsetting eyes, dilated scalp band because it is very fragile. It is not developed. Okay, so infant period will be like that. And there is a the frontanels. Okay, the anterior posterior frontals will be bulging. Okay, so we have seen in the newborn condition anterior and the posterior frontal that will be bulging. Okay, so these and all in the infant symptoms. So if you are just pediatric going, the 2 years child, okay, just remember 2 years child with the presenting hydrocephalus, these are the symptom will be there. So except they will be. So if they mention you dilated the frontal bulging, you should not choose because the anterior frontal will close when 1.5 years. Posterior will be 1.5 months. So 2 years, there is no frontanels. How it will be bulged. Got the point? So that should be very careful. Infant, that's an infant symptom differ with the pediatric. Pediatric symptom, child is little weaker. There is irritability, lethargy, headache. It is like a same, little like a adult symptom. Okay, headache, nausea, vomiting. These and all will be. Okay. Management. What is the management? We have to keep the NPO status and reposition the head frequently. Why? Preoperatively, hydrocephalus patient reposition very important because there is already hydrocephalus make the brain, the part of the brain will be very big, head will be very big. So edematous. So when they just put like that, there is high chance of pitting edema. It will just go inside. It will just pressing the organ inside. So we have to be frequently reposition the child in the preoperative. That is very important to prevent the pressure ulcer. Got the point? Next, surgical management. We will put the VP or VA stent. VP means ventricular peritoneal. Through the ventricles connected with peritoneal stent or ventricular atrial stent. And through the heart and the ventricles will be connected. So whatever CSF is there, it is drained. Okay. Post-operative. After the surgery, you have to remember non-operative side. So now here the operated side, here they have to lie down. So now operative side, we have to position the client, okay, child. And if it is ICP increase, okay, we have to decrease the ICP because already CSF increase. So high chance of increase ICP. What is ICP? Intracranial pressure. Okay, that is high chance to increase. So we have to put the baby in the semi-fowler position, 15 to 30 degree only we have to be just put the child. Okay, it's not should not be higher than that. So always you have to remember to increase ICP, you have to put 15 to 30 degree head elevation. Okay, and we have to daily monitor the head circumference, okay, any difference, and we have to strict intake output chart. These are the management you have to see in the hydrocephalus patient, okay. Head C is very important, and there is a semi-fowler 15 to 30 degree only we have to elevate to reduce the IC, okay. So next one, it is called cerebral palsy, okay. So in the cerebral palsy, what you have to remember, it's chronic disability, okay. It's mostly there is a patient will be having the impaired muscle movement, okay. Muscles will be impaired movement, and the posture will be, if there is a impaired posture changes, and there is a muscle tone will be lost, because the problem in the cerebral area, okay. Cerebral area not acting. Palsy means what is mean? Paralysis, okay. There is a palsy in the cerebral area, so that is affecting the muscle movement, posture, and the baby is, you see the baby, it's very rigid baby, okay, very rigid, and irritability, crying will be there, and the feeding difficulty will be there, and delayed developmental milestone, okay, delayed developmental milestone, and persistent of the reflex will be there, like a monotonic neck reflex will be present, okay, because it will be just 3 to 6 months, it will be gone, okay, it will should be disappear in the childhood. Monotonic neck reflex and all should be disappear, but the cerebral palsy neuro disorder, so neuro impairment, neural, so there is a continuation of motor plus tonic reflex after 6 months also. Got the point? So what is the management? Cerebral palsy, we will give antispasmodic, okay, and physiotherapy they will do, and position the child upright after the meal, because cerebral palsy, the patient will be having the muscle problem, alter muscle. So if you just eat after the dying down, there's a chance of aspiration, because all muscles are weakened, okay. So you have to remember, position the child after eating, upright position to prevent the aspiration. Got the point? We'll move on to the next condition. It is called spina bifida. It is important condition, okay. So you'll see the spina bifida. So here, see the normal spine. Second picture is spina bifida occulta. Okay, there is some deformity, okay, but it is not protrusion, okay. Second, meningocele, there is protrusion. Meningomyelocele, there is protrusion, and it will be involved with the neural tube also. Got the point? So these are the pictures also I will be explaining you. So here you have to remember what is spina bifida. We have the neural tube defect, okay. Failure to close the neural tube. Yes, the spinal cord area neural tube will be failure to close in the during the embryonic period. So when the baby is born, there is a open neural tube will be there. So mainly cause is the folic acid deficiency. We have already seen in the OBG. Folic acid deficiency will cause the spina bifida neural tube defect. Okay. So we have two types mainly. Remember, don't confuse. First is called spina bifida occulta. Second is called spina bifida cystica. Okay. So spina bifida occulta, what you have to remember, there is a post-tibial vertebral arch failed to close in the lumbar sacral area. Okay, remember, occulta means post-tibial vertebral arch is there, but it's not closed in the lumbar sacral area. Only not closing, but there is no involvement of brain and spinal cord. So no neurological defects. Okay, got the point? Spina bifida occulta, there is no neurological defect. Second one, spina bifida cystica. In under the spina bifida cystica only, we have meningocele, meningomyelocele. Okay, so meningocele, what you have to remember, the lumbar sacral area, there is a protrusion. See, meningocele, there is a protrusion is there. Okay, but see the neural tube, that will be not affected. Got the point? So only the involvement in the meninges, CSF, but not in the neural tube. Okay, CSF and the meninges only involved. Okay, because of that, no neural tube defect in the meningocele also. But in the myelomeningocele, there will be the lumbar sacral area, one protrusion, and it will be covering the only thin membrane. See here, there is the involvement of the neural tube, so only covering the thin layer. Okay, so that is called myelomeningocele. So here you can see that any time there is a thin layer can be rupture, can be leakage. Okay, you have to carefully monitor. Only you have to put the baby in the prone position supported with the pillows. Okay, and it will cause meningomyelocele involved in the meningitis, CSF, spinal cord. So there is a neurological defect. So in the lumbar sacral region only, mainly there is a problem. So in that lower part mostly will be paralyzed, no bladder and the bowel control will be there. So that and all problem will seen in the only myelomeningocele. Understand the condition? You should not be confused. Okay, we have two types: spina bifida occulta. There is no neurological defect. Spina bifida cystica. In there is two conditions: meningocele, meningomyelocele. Meningocele, there is a meninges CSF involved, but the neural tube not involved. Okay, but there is a protrusion. But the myelomeningocele, there is everything involved. Some CSF, spinal cord, meninges, everything involved. So it will be cause the neurological defect. Okay, got the point? So clinical manifestation, see below the level of protrusion. What is the, where is the protrusion? Before level, there is no sensation, no movement, no reflex. Okay, flaccid paralysis will be happen in the legs. Bladder and the bowel function will be altered. Okay, so you have to remember how to perform the Graves maneuver. What is the Graves maneuver? For like this babies, okay, baby with the spina bifida, cystic anta, what they will do, they have the neurological problem. So they will apply the firm pressure over the bladder so the urine will come out, eliminate. Okay. So apply the firm pressure on the bladder because there is no control, no voluntary movements. Okay. So apply firm pressure on the bladder so to eliminate the urine. Okay. So this is called only Crader's maneuver. Okay. So next condition, we will move on to the Down syndrome. Okay. So we have so many conditions in the pediatric, but only it is small topics. Okay. The thing is you have to just select the important notes, take it out. Okay. Down syndrome, otherwise called, it is trisomy 21. Okay. Down syndrome, otherwise called, it is trisomy 21. Remember, okay. It is a chromosomal abnormality, a genetic disorder. So mainly cause additional one extra chromosome. That is the problem. Okay, so in the 21th pair, that's additionally one chromosome will be added. Normally, we have 23 pairs, 46 chromosomes. Okay, 23 pairs, so 46 chromosomes. Now here, if you see the Down syndrome, there is in the 21th pair, there is only one addition. So there is a 47 chromosome will present in Down syndrome. Okay, who under risk? Woman with the above 34 years getting pregnant and hypothyroidism, pregnant mother. So these are the patient will be risk of the Down syndrome. Okay, what is the clinical manifestation? We'll see gray spot on the iris. So in the iris, there is a, the space will be in the gray spot. Okay, iris field. So that is a overcurved helix, means the ear will be very short and it will be overcurved helix. Okay, and it's like a bending. Okay, so it is not stand, it is like bending. That is a overcurved, well, the curving or will be there in the ear. Low set ear will be there. If you see just straight line, the ear will be started there. But if you see the Down syndrome, it is down. Down part only, the ear will be there. Low set ear. Speech impairment will be there. Eyebrows will be separated. Poor eye contact. If you speak also, they won't listen. They won't keep the eye contact. High risk for the leukemia, cancer, okay, blood cancer due to the immune dysfunction. And there is one more thing, leg will be sandal sign. Okay. So what is the leg sandal sign? He is the separation of the wide gap between the big toe and the second. Okay. So if you see leg is there like this, see separation, a wide gap between the big toe and the second. So in this between there is big gap. That is only called the leg sandal sign. Okay, got the point? So what is the diagnostic test during pregnancy? Dribble test. So to identify the Down syndrome during the pregnancy, what test the doctor will perform? It is dribble test. Remember, okay? So combination of estrogen and the human chorionic gonadotrophy, HCG hormone, and the AFR, alpha fetoprotein. So this is to diagnose Down syndrome, congenital abnormality. Okay. So management. What is the management we will do for the Down syndrome? We have to positively reinforce and we have to give the supportive management and safety and correct the structural deformity. We have seen the sandal, the patient will be having the sandal leg sign and the patient will be having some of the signs and symptoms like that. So we have to be see that. And one more important point I forgot to tell, it is simian line. See, if you see the palms, we have two lines, right? Two. Okay. But if you see the patient with Down syndrome, only single palmar line. Okay. The single transfer palmar crisis, that is called simian line, present in the Down syndrome baby. Okay. So we'll move on to the next condition. It is called cryptorchidism. Okay, what does mean by crypt orchitism? It is the undescended testis. Testis is not descended. Okay, it's not coming to the normal plane. So usually it is happen in the at birth. So failure to descend in the testes. Okay, scrotal cavity will be there. So inside the scrotal cavity should be testis, but it should be failure to just come down. So what is the causes you have to remember? It is here, if you see just after the birth, if you assess, there is absence of testis because of prematurity. Okay. So what is the management you have to remember? If you have to palpate and see the inguinal area followed by the abdominal. So from the abdominal, then the inguinal you have to palpate so that sometime prematurity, there's a testis, it is in the inguinal area. So from the abdominal, if you palpate, it will just come down to the scrotal cavity. Okay. Sometime it is not come down. We have to wait until 12 months because normally there is a spontaneous descending of testes will be happen within 12 months. So if it is not happen, we have to go for the surgical management. It is called arteriopexy. Okay, arteriopexy, the surgical management. It will be performed between the 1 year to 2 years. Okay, so 1 year to 2 years, we have to perform the surgical management. So before that, we won't perform. We will wait for until 12 months to descend the spontaneous testis descended. Okay. So if it is spontaneously not descended only, we will do the arteriopexy. Okay. So at the discharge time, what is the important counseling for the baby with the arteriopexy surgery or the undescended testis? What is the thing you have to give? Counseling about the parent, about the fertility of the child. Okay, because future fertility can also leads to the baby will be having cryptorchidism. Okay, what is cryptorchidism? It is undescended testis. Okay, so remember that disease condition. What is that? That is you have to be understand. That is very important. Okay. Next, we will move on to the Wilms tumor. What is Wilms tumor? It is otherwise called nephroblastoma. Okay, tumor in the kidney. Okay, so we will call the Wilms tumor. So nephroblastoma, and there is a peak incident, mostly 3 years of child. Okay, boys can be affected, left kidney mostly affected. So Wells tumor, if you see the absence of iris will be there, aniridia. Okay, we will call aniridia. It is mean absence of iris. Genitourinary defect will be there. Mental retardation also will be there in the Wilms tumor. Okay, so what are the stages? See here, stage 1, stage 2, stage 3. So stage 1, see here only tumor in the within the kidney. Okay, it is in the small part. You can completely resect. Okay, take out. So stage 2, it is complete in the extent of throughout the kidney. So these also we can be removed. Okay, resected. But the third stage, the lymph node will be involved. Cannot be take out because lymph node also involved. Then the fourth stage, it will be going to another organ. Okay. For the fifth stage, it is extremely bad, bilateral, both kidney fully affected. Okay, so these are the stages you can see. So what is the diagnostic? We will do a CT, MRI, but the biopsy cannot taken because biopsy can cause rupture and it will be metastasis. What is metastasis? It is the spreading. Okay, so cancers are metastasis. So if they do the biopsy, that is the rupture can happen, can be metastasis to all throughout the body. Okay, so management will have to be monitor the vitals, avoid the abdominal palpation because abdominal palpation also will cause the rush. Okay, rupture will be there in the rupture can happen in the kidney, and we have to measure the abdominal girth daily. Okay, any distension is there, any growth of the tumor. Okay, and we will give the antihypertensive medication. Okay, so these are the things because kidney will be affected. So BP on maintain, so antihypertensive medication also they will stop. Okay, so these about the Wilms tumor. Surgical management of Wilms tumor, it is the nephrectomy, removing of the kidney. Okay, nephrectomy, it is surgical management. So post-operatively, what you have to remember after the kidney removed, first 24 hours, they have to completely bed rest and we have to turn the patient supine to the non-operatic side and we have to check for the bleeding. Okay, in the back of the body, we have to check for the bleeding. We have to monitor the bowel sound. Okay, because why? Increased chance of intestinal obstruction can happen after the surgery. So monitor bowel sound is important. Monitor the color of the urine or any infection. Okay, so monitor the color of the urine and any infection, we have to look for that. Nephrectomy patient. Got the point? So this about today class. We will just see the next topic in the tomorrow class. Okay.